Welcome everybody to the event today. Today's event will cover the menopause, critically both the clinical aspects and the transformation at work to embed the menopause, both in terms of awareness and formal actions you might want to progress. I'm really pleased to welcome our panel of experts today, some of which have been absolutely central to the transformation work in NHS England, and I'm very pleased that to see them all here today. As you'll know, menopause has grown in, let's say, interest over the last few months, which is all very welcoming. But what's critical for us as formal organisations and as an NHS that employs almost 80% of staff recognised or declaring as female is that we need both the clinical evidence and expertise into that, and less perhaps reliance on declared experts. So I'm looking forward to a very formally, very expert discussion today. Welcome everybody to put their comments and questions in the chat box, and we'll pick that up with our panel meeting at the further into the session. So my name's Jackie McBurney, and I set up and chair the NHS England Menopause Network, and I also link into the Cross-Government Menopause Network, and obviously have the benefit of sharing and collaborating with that wider civil service connection. So I will invite panel members to introduce themselves as we make a start. First on my list is Kathy.
Good afternoon. Thank you, Jackie. So I'm Kathy Abernethy, Director of Menopause Services at Peri-Health, which is a personalised menopause service delivered through the app. I'm a British Menopause Society registered menopause specialist. I'm still past chair, trustee and medical advisory council of the British Menopause Society, which is the professional organisation that leads standards of care around menopause. I'm on the NHS England pathway group, clinical reference group, and I'm sometimes described as a menopause enthusiast, which is probably a good description. Jackie, do you want me to go straight ahead?
Yes, please, Kathy. We'll lead into your session.
Thank you. If we could go on to the first slide then. Thank you. So I'm pleased to be invited to talk about this afternoon because it's something that's really close to my heart and something which professionally as a nurse has been really important. And I know that others on the call today will have had a similar experience to me, which is that you work in an NHS menopause service, quite difficult to offer that to staff, but nonetheless you have queues out of the door from clinical staff who are wanting your advice and tips around menopause management. So I've been asked this afternoon to think about actually what is menopause, how does it affect people, and in particular, how does it affect people at work? Next slide. So what do we actually mean by the menopause? Because strictly speaking, physiologically, all that we mean is it's the time that your periods stop. And if it was that simple, wouldn't it be easy? Most of us wouldn't mind at all if it was just the end of periods. But it's because what comes with the menopause is the peri-menopause or the climacteric or the change, whatever language you want to use. And this usually occurs somewhere between 45 and 55 with an average of about 51. And symptoms of the peri-menopause are the problem. It can last for a long time. I'm often asked, how long is this going to go on for? And there is just no set answer. For some, it will be really quick, a few weeks or a few months and it's over. For others, it can be months or years or even decades for a few people. So those symptoms are what bothers us as we go through the menopause. And when I think about the symptoms in a moment and you begin to think about how many parts of the body and the anatomy are affected by the menopause, you can begin to understand how it affects us not just at home, socially, but also at work as well. And we're talking about natural menopause mainly today, but we need to really also recognise that for many it won't be a natural event. It will happen early, under the age of 40 in 1 in 100 people, under the age of 30 in 1 in 1,000. And maybe you've gone through menopause as a result of cancer treatment as well, and that comes with its own complications and consequences as well. Or even for benign treatments, maybe you've had your ovaries removed for polycystic ovary disease or endometriosis, or benign cysts, for example. You may be going through menopause as a result of surgery. So the impact of menopause will affect a lot of people at different times of their life and different stages. Next slide. And as Jackie said, we have seen a sort of resurgence, if you like, of menopause. I've worked in menopause for a long, long time, and I've seen the ups and downs of media coverage from the start of, you know, we don't talk about it, it's a taboo, we don't want to talk about it anywhere, especially at work, right through to now where we've had people like Davina really making the conversation open. She has really helped the conversation. And now it's not really a stigma. I don't think it is a taboo topic at all. But I think if there is anywhere that it's difficult to talk about, it is at work. And that's the issue that we're talking about today. In the States, Michelle Obama, interestingly, didn't talk about her menopause when she was wife of the president, even though that's when she went through it. That was perhaps a step too far. But afterwards, she said, look, half of us are going through this, and yet we live like it's not happening. And I think in the NHS, we're beginning to realise that we have to acknowledge that it affects so many people in our workplace and at homes as well, that we have to address it. And you probably remember Louise Minchin, she's on the BBC. She came publicly to talk about her menopause and said, surely it shouldn't be that hard. But it did feel like I was walking over the edge of a cliff. And she was talking about actually having to embrace the conversation of symptoms that were happening to her at work. And that's somebody who's really confident, really in the public eye, has a prominent position in her place of work. What about those people who are not so prominent, who are the sort of the absolute backstay of the NHS, as it were? Next slide. So at work, there has been a lot of discussion around it, and I think it has grown from 2015, where Sally Davis, who's the person on the right here, said, look, we should be discussing menopause at work as openly as any issue. Prior to 2015, there was no documentation, there was no consideration, the government were not interested in it. To be honest, the NHS were not really thinking about it either. But she was the Chris Whitty of her time. Now, she wasn't as well known because we didn't have COVID, but she was the medical person telling government that we should be discussing menopause at work. And there was a report which came out which she was able to frame her evidence around. And we know that people do hide their symptoms at work. You know, can you talk to your manager? Can you get adjustments if you need to? It can be really difficult. And this is not a women's issue. If anybody ever says to me that menopause is a women's issue, I shoot them down straight away, because it's not. It's an everybody issue. If it's affecting somebody at work or at home, then it's affecting those around them as well and having an impact on the place of work and their colleagues. So it has to involve everybody at work, not just women in the workplace. Next one. We know that here in the UK, the demographics of people working in later life have definitely improved and increased. And we know that the over 50s are now the fastest growing demographic in the UK workplace. So in other words, if you're over 50 and you're going through menopause, you are likely to be working alongside it. 3/4 of us are working our way through the menopause, so to speak. And yet the impact of the symptoms that we have and that people describe mean that sometimes people do consider giving up work. And we know that up to around 1 in 4, according to surveys, women say that they are thinking of giving up work because of the challenge of combining the menopause with the work pressures. And surveys suggest that maybe 1 in 10 actually do give up work. But we don't have many records about that. Because if you're the one that's quitting your job because of the menopause, it's very unlikely that you're going to feed that back to your employer. You'll say that you're leaving for family reasons or for stress-related reasons, or you're downsizing, or you're not going for the promotion for another reason. And yet the root of it may well be the menopause. And this is a really important issue for employers, because although it's important for individuals and we want to help individuals, actually this is a real issue when we're thinking about retention, promotion, and trying to keep our senior women as well, because we need to really address this. And when you take into account that nearly half of the working population of the NHS identify as women between the ages of 45 and 64, you can begin to see why it could really be a problem within the NHS workplace. And as I said, it's not a women's issue. And I think the stereotype picture of somebody going through menopause is a middle-aged woman. But actually, it could be somebody much, much younger than that. Or it could be somebody in her 60s who's still experiencing menopause symptoms. Or it could be somebody who doesn't outwardly identify as a female at all and is still experiencing menopause symptoms because of their physiological still having ovaries. So we need to take that into account too. Next slide. So when I talk to women, what they say to me is, you know, yes, okay, we see all this stuff in the media about trying to stay young and stay youthful and try and not talk about the menopause and pretend we're not going into the menopause. You know, we see all these articles around coping with menopause or hiding the menopause, but actually the reality is, you know, it's this: I need to be able to do my job. I just need to have a good night's sleep. What a difficulty that is for some people. And probably the other two are the ones that I hear the most. I'm just not me. I'm not myself. I just want to feel normal again. And part of my job is to, I always feel, is to get people back to normal. Whatever treatment options, whatever lifestyle changes that we're suggesting, it's not to create superwoman in midlife. It really isn't. It's just to get people back to normal. And one I hear a lot from working people is this last one. I'm hanging on in, but only just. So I'm doing my job. I'm struggling. It's difficult. I can't discuss it properly, but I am doing it. I can still do the job that I was competent at, but I'm hanging on by the skin of my teeth and I'm exhausted. And it's a horrible feeling to have. And that's why we try and come alongside people and actually improve their menopause with all the advice that we can around, not just HRT or treatments, if that's the option, but also all the lifestyle measures that we're going to be talking about in the next session. Next one. We hear all the pictures around menopause. We must remember that not everybody even gets symptoms. It's not always a negative experience for all. It can be a very liberating experience for some people as they go through that time when their periods stop, they feel well, they have no more cycles, they don't need to worry about contraception, they feel very positive moving forward. And about a quarter of people report no symptoms. But the other 75%, which is a large number of people, do report symptoms of varying severity. And around a quarter of those have, in surveys, graded them as being either moderate or severe. So they're troublesome enough that they have to make adjustments. So that might be as simple, well, not always simple in the NHS, but it may be as simple as having a fan on the desk or easier access to drinking water, for example. It may be that they have to make more difficult adjustments. Maybe they need to put in requests for things like changes in the number of night duty shifts that they're doing, or starting earlier, finishing later. Things like that, which can be very difficult to accommodate when your workplace is already under intense stress. And I can't stand here as a menopause clinician and only talk about symptoms. We don't have any time today to talk about the health consequences of menopause and steps you can take to improve your health. But I firmly believe that the menopause is the time to evaluate your health and make changes, which we all know what the health changes should be, but it's not just for now, it's actually for the future. And so after the menopause, we want people's health to be really good in the long term as well. Next slide. So I've put this up, I'm not going to go through them, but it would just be good to remind ourselves of some of the most classic symptoms of menopause. And I probably could have put up 3 times more number of symptoms, because there's any part of the body which could be affected by estrogen loss after the menopause. But these are very typical things, and things like flushes and sweats, you know, we can all relate to those. They're classically menopausal. Difficulty with uniforms, synthetic fabrics, not being issued enough uniforms, for example. These things are real issues. Maybe you're in a boardroom, maybe you can't control the temperature of the place that you're working in. There can be a real problem around flushes and sweats. That constant headache, which is usually not a focused headache, it's a generalised headache that you can experience. Overwhelming sense of tiredness and fatigue that even a good night's sleep doesn't leave you refreshed. These physical symptoms are bad enough for some of us, and you may not always realise that some of these are not even related to menopause. Maybe you look at them and you think, well, I didn't know that joint pains, for example, or palpitations were even possible as menopause symptoms, because nobody prepares us for it. Nobody tells us what the menopause can bring, although that is improving. So those physical ones are sort of bad enough, but it's the ones on the right, interestingly enough, which seem to disturb women more. They may not be as prevalent, so maybe not as common, but they are still quite common, and they're the things that really affect us in the workplace. Memory issues, you know, that feeling that you just can't remember, what did I go in this room for? Post-it notes all over your computer, all over your desk to try and remind you of what you need to do. Concentration issues. Maybe you were that person who could be at your desk first thing in the morning and work right through to the end of the day without a break. Maybe that was almost expected of you and you could do it, but when you get to the menopause, you can't. You just can't do it for so long and so hard. You need to take the breaks. Brain fog is really common as well, and at work that's really worrying. It starts to cause anxiety. You know, am I going to forget something really important? Muddling through. It's a bit like cotton wool brain is what people describe it as. Clarity of thought, things which are so important to us in the workplace. And that can lead to feelings of anxiety, panic attacks sometimes, and also feeling quite irritable, tearful and moody at the same time. These symptoms rarely come in one go. Most people don't get all these symptoms, thankfully, but they can come and go in waves. So you may well have a few of these symptoms for a while, then they disappear, and then what happens, you get something else for a little while, and they will eventually go, most of these symptoms. Once you get through the menopause, most of these things will settle. But how long does that take? As I said, you just can't predict it. Next one. Thank you. So when we talk to people, how does it make you feel at work? Because it's not just that physical thing, it's that whole environment at work. And this is some of the things that people have said. Sometimes I wonder what others think of me. Do they see me as less competent because of the way that I am? I'm not. I can still do my job, but I feel as if I'm portraying myself as less competent, and people around me are being very impatient with me. If only I could explain that this is my hormones, not my brain, maybe then they wouldn't belittle me. And sometimes at work, menopause can be made a joke. And when you're the butt of the joke all the time, it really is not good at all for anyone. My confidence is smashed. I forget things. I become tearful. I get angry. This is not me. And this is really concerning. I feel less of a person, less strong, less respected, simply because I'm going through the menopause. We have to overcome this. We have to help and support people so that these kinds of statements are not made. Next one. We also have to acknowledge that when we're going through the menopause, we're never going through it in isolation. We have all these other factors going on in life at the same time. We are affected by life. So we have anxieties, we have stressors, whether that's family life, whether it's work life, whether it's work stress, whether it's weight management that we're battling, whether we're trying to fit in our exercise, whether it's the family support that we have or we don't have. And maybe it's the culture and attitude to both aging and to the menopause, which also influences how we experience the menopause and how we feel about it. The menopause, as I said right at the beginning, is a physiological event, but it's come to mean a whole social construct. And we start talking about menopausal women and all the connotations that that has. And we have to overcome those as well when we're going through it. Next one. So what do I think people know? Well, I think people need to know that it can go for a long time. Symptoms can vary and everyone is different. Some people want to talk about it, some people will not be wanting to talk about it, and we need to have capacity for both. And you can't fix someone's menopause. We can advise, we can support, we can offer treatment, but at the end of the day, we just understand what people are going through is the absolute first step. Next one. So I think in terms of the workplace, and I think this is relevant to the NHS as it is to any other workplace, which is that we need to make sure that the bottom level of this pyramid is really supported and covered. So everybody in a workplace needs to understand what the menopause is. And if we get that level right, it makes the other levels further up much easier. If you need some support, some minor adjustment, it's a non-issue. Your manager understands menopause. They know the pathway of support that's open to you. So you're able to get those changes that might be necessary. A few people might need more major adjustments, and there will be a pathway or policy in place, hopefully, for that to happen. And I would like to hope that we can get to the situation where nobody has a job review or a performance review that's negative based solely on their menopause. We have to stop that from happening. And it works by getting that floor level right, where everybody understands what's happening. And that's what this kind of webinar is about. Next one. So maybe you're here because you're learning about menopause. Maybe you're here because you're experiencing menopause. Maybe you just want to know what can you do as an employer. And I think simple things make a big difference. It's listening and understanding, because nobody teaches us about menopause. It is now on the school curriculum, but it's 2 sentences on the curriculum. The generation going through menopause at the moment have never been told what to expect. And if you're somebody who's not going to go through menopause, how would you understand it if you've never been told it? So we need to encourage this place of work where we understand people. I think we're a little bit like where we were with mental health a decade ago. Let's just understand that this is something which really affects people at work. And if they express a problem, you're not expected to fix it. You're expected to understand it and to ask them if they consider the solution. And very often they will know the way that they need to help themselves, but they don't always have a pathway to do so. And that's what we can do. So you need to know the pathways in your own place of work. Have you got any guidance? Is there a menopause policy? Do you offer any support? Do you have a clinic? Do you have any resources? Is it evidence-based? Where are you pointing people to? All of those things are really important to consider. Next one. And some things you know, probably, hopefully you'll never say these things, but you know, I hear these things time and time again. Aren't you too young to be going through menopause? You know, we talked at the beginning, you're never too young to be going through menopause. You might be 24 or even younger and still experiencing menopause. It's perfectly natural. Yes, it is perfectly natural, but it can be a big deal. Oh, my so-and-so's was easy. My wife's was easy. My mum's was easy. What's all the fuss about? We really need to avoid those type of conversations and statements. And then the other extreme, why don't you just take HRT, especially if you're an advocate of HRT and it's been helpful for you? You sometimes see it as a quick fix, and it's not always. So we need to avoid that as well. And then this one about how can you be menopausal, this questioning, and we need to understand the whole variety of people that might be presenting with menopause who are not your stereotypical 50-year-old. Next one. So what is the NHS doing? Well, the NHS is much further along than it was 5 or 10 years ago. It's probably not anywhere near perfect, but some trusts are bringing in policy, so it's worth asking whether there's a policy in your trust. I know that there's been national consultations on uniforms, and I know that within individual trusts there have been a lot of discussion around uniform alternatives and access to more uniforms if necessary. This is one of the areas where COVID actually helped us, because there were very similar issues that were addressing people not going through the menopause as well. The electronic staff record can now record menopause-related absence, which you couldn't do in the past, so that's a positive step. And from my own perspective, the Peri-menopause service personalised support is now offered in 11 NHS trusts and also through NHS England and improvement to staff. So that's a tangible personalised support that they can access. NHS England has supported the Wellbeing of Women Workplace page, which is a sort of promise, if you like, to do better. And the NHS England Menopause Pathway is well underway, which is looking at how workplaces, not just the NHS, but including the NHS, can improve the whole access to menopause care across both the NHS for patients, but also for staff. And that's really useful. Next one. This is just to remind us that there are treatment options, there are things available, and I know that Deborah's going into this, so I'm not going to go, but just to say that you do not have to put up with your menopause. There are lots and lots of different ways of managing menopause symptoms that stop way before HRT. Maybe you will end up with HRT, but there's lots of other things you can do as well. Next one. And some of you might be thinking, okay, so what is this, Pepi? So just to advise you, it's a digitally accessed personal menopause service, and there are NHS trusts now who are signing up to this. So once you access it through your phone, you're then talking to real menopause nurses like me on a personal level, one-to-one, Monday to Friday, 9 till 9. Whole evidence-based library of resources. We have broadcasts, webinars, all sorts of information, but it means you can ask your personal questions to somebody who knows what they're talking about, and then you can go on to get the help that you need. Next one. I'm going to skip that one. Next one. Thank you. So I'd like to finish it there, and I'll hand over to Debbie.
Thank you, Kathy. And I'm Debbie Holloway, and I'm going to talk about treatment options, so self-help and also when to seek medical help. And I'm a nurse consultant in gynecology, a specialist in menopause, and also a trainer for menopause for both nurses and doctors with BMS and the faculty. So next slide, please. So I'm going to talk about the management. So I am going to talk about lifestyle, and I think some of the things that Kathy said are going to be echoed in here as well. I'll talk about complementary medicine as well, and what evidence we have behind some of those things for menopause help. And also going to talk about alternatives and then HRT as well. So I'm going to try and cover those in the next 25 minutes or so. Next slide, please. So in general, I think the menopause is a quite distressing time for lots of women. Some women don't find any problems at all, but it's important to know the symptoms that Kathy's been talking about so that you can work out, are they menopause symptoms or is there something else going on in your life? And then you can work out, once you know what are menopause symptoms, how to handle them. There is no one size fits all. So some people just need some lifestyle, some people need some prescribed medication, other people need HRT, lifestyle, alternative therapies and everything. And it is sometimes a little bit of trial and error to work out what's the best combination for you and what measures will work for you. But in general as well, I think it's time to be kind to yourself. And I think as nurses, we're not particularly good at being kind to ourselves, and we're quite hard on ourselves a lot of the time. Next slide, please. So a good idea when you're going through the menopause, because it can be quite difficult to pinpoint all of those symptoms, is to start keeping a bit of a diary or a log and look at the symptoms. There's lots of commercial ones out there, but even just a normal straightforward diary, look at the symptoms you're having and look at what happens when you have those symptoms. How does it make you feel? Is there anything that triggers it? So traditionally, things like caffeine can trigger a hot flush for some people. So have a look if there's any triggers. Other things that you might not think about is if you eat late at night, you might have a really bad night with night flushes and be up and down and not feel very well. So it's important to look at the whole of your lifestyle and get a holistic picture. Then when you know what your symptoms are and what makes them worse or better, you can also add in things like stresses, what was happening at work, what was happening with your family, etc. By keeping a track of these, including your periods, if you're still having periods, you'll be aware of what's changing. And then this is really useful when you go and speak to someone as well, because sometimes it's quite an emotional time and it can be quite confusing. If you've got it written down, it's quite objective evidence of what you're feeling. So really important to keep that. And then don't put up with your symptoms. There is support out there. There is things you can do. So you really need to go and speak to someone about them or look online at some evidence-based resources. Next slide, please. So staying cool, it's really easy to say staying cool, and after the last week or so that's been really difficult to do. But some of the things you can do is dressing in layers, so not lots of heavy synthetic clothing, lots of light cotton clothing. Some of the stuff that's made with bamboo fibres is quite good at absorbing some of the sweats from having a hot flush and a night sweat. Bed linen as well, same sort of thing, so it absorbs the sweat so that you don't end up waking up all cold and in a layer of sweat. Dressing in things that you can get off easily, so there's nothing worse than having a hot flush and being stuck in a really thick jumper and just having a bra on underneath, because if you're presenting in a meeting, it's really not good to be taking off your clothes. You can use things like, you can use a facial spritz with some cold water in, and you can get them commercially, or you could just buy an empty bottle, fill it up with water, keep it in the fridge and then use that. Things that other people have used, things like baby wipes kept in the freezer so that you can take them out and they're really cold and put them around the back of your neck. You can get a chiller pillow that goes on your bed. Having lots of fans, so you can have desktop fans, you can have fans around the house, lots of ventilation, which is really hard to do in the NHS, but you can have handheld fans as well. And then there are commercial, there's an ice thing that goes around your neck that keeps you cool, looks like headphones. So there's all sorts of stuff out there that you can use. So it's worth having a look round and then just try and maintain that temperature. Next slide, please. So managing the menopause, we can look at all the things that we can do. And as Kathy mentioned, it's a really good time to look at how you are, to look at what you're doing and to try and increase your health and increase your health to its optimum around this time. So we need a good diet. We need it good balanced with calcium, magnesium and vitamins B and D, but the calcium, magnesium and D definitely for your bones, because when you start to lose estrogen, your bones become a bit thinner, so you can be at risk of osteoporosis. So it's important to look after those bones. We need whole grain foods with lots of protein in, fibre, sometimes some phytoestrogens, and I'll cover those in a minute because they're plant estrogens that you could increase your intake to help with some of the symptoms. Look at what carbohydrates you're having, look at decreasing the processed foods and the sugar, and if you do have to snack, then try and snack on things that are more healthy, because around this time you are more prone to weight gain as well, which I'll come on to. So lifestyle choices. So we do know that caffeine can trigger hot flushes. Also, caffeine's not very good for sleeping, and it can be not very good for anxiety. So you might like to look at that. And alcohol, again, alcohol's not very good for bones, but it also can trigger some flushes, night sweats, etc. So again, looking at things that you're doing, and then smoking. So overall, smoking is really bad anyway, as we all know, but we do know that it can make some people have flushes, and it can impact generally on health around this time. So it's a good time to just think about what you're doing and things that are really easily within your control. So we do say, if you find that caffeine is your particular trigger, it doesn't mean that you can never ever have a nice coffee or an espresso or something again, or a cappuccino. All it means is that think about whether you want that caffeine in that situation. So it might be that if you're about to go into a meeting or you're about to do handover on the ward, you might not want the coffee at that time because you know it's going to make you hot and have a flush. But if you're sitting at home on a Saturday morning, watching telly, reading the paper with a fan on, you might want a nice cappuccino or you might want a nice espresso. So it's about sometimes the timing of what you do. Exercise around this point is really important because it can help with the symptoms and it can also help with sleep, but it's also good for balance and flexibility because we want to try and prevent people from falling over because the bones do get a little bit thinner at this time. It can help with cardiovascular, so keep your heart working. It can help with muscle strength, and then just to keep moving can help with the joint pains for some people as well. So really important all over for that one. Next slide, please. So as I've said, keeping the weight down. So we do know that some women, if they're overweight, they can have more severe symptoms. So particularly the hot flushes and night sweats. So it's important to try and keep the weight down for that. Keeping the weight down for your heart is really good. It can help with your joint pains too. It can help reduce the risk of some female cancers. So if we're looking at optimizing our health, particularly endometrial cancer, so lining of the womb cancer and breast cancer, and it's good for the pelvic floor as well. So really important to try and do that as a holistic measure. We know that it's a very stressful time, so there you can look at some stress reduction techniques, such as relaxation, such as CBT, and there's a book there and there's a leaflet on the Women's Health Concern website looking at CBT for hot flushes and night sweats. Yoga, Pilates, mindfulness, all of these things can be quite useful. It's really important to take time for yourself and just think about what you can control, reflect on what you can control, and then try and not worry about the things you can't control, because the menopause can create anxiety around things that you were never anxious about before, such as things like, what shoes do I wear? Where do I put this in the fridge? Things like that, that you can't really control or shouldn't really be affecting your mental health. Next slide, please. So stress, really difficult at work, particularly in some of the environments and having worked through the COVID, but it's important to think about things, and you might need to write a list. If you're feeling overwhelmed and you're feeling that you can't think about things, write a list. Think about how you write the list. Think about saying no, and this is a problem that we all have, I think, that we say yes to lots of things and then stress that we've got to do them. And it is a time when you can say no, and you can say no if you don't want to do it, or you can say no if you're too busy. Do the things that you want to do that bring you enjoyment and that you like doing. And this can help with your mental health as well. So really important to think about things like that. And as I've said, for stress as well. So CBT, yoga, caffeine, etc. All of those things can help. Sleep can be an issue. So try and get a nice bedtime routine. So a downtime, no electronic gadgets in the room. Look around your bedroom and think, what do I need in here? Do I need a telly? Do I need a PC? Do I need my phone? Think about things you can get rid of. Keep it a nice cool room, lots of cold water to drink and a fan on if you can cope with that, and then maybe a chiller pillow, and look at what bed linen you've got and what you're sleeping in, and then just try and have some downtime, try and think about things, try and get into a good routine with sleeping roughly the same time if you can each day, getting up at the same time. Try and have a positive mindset, try and turn it around and think, this is a really good time for me. This is a time when I've got these symptoms, but this is a time of change, and I'm going to be much better at the end of this. So make it positive, make it time for yourself. For the brain fog and for concentration, forgetting and things like that, sometimes you can have a routine. So if you had a bowl by the front door where you always put your keys, you don't have to spend a lot of time then running around the house trying to think, where did I put my keys? And try and think about things like that. You do have to change. You do have to adapt how you're thinking about things. And post-it notes, as you said, Kathy, all over the computer, having lists, there's lots of things you can write down, cross them off if you need to. And I think you'll probably find that most of the time you don't actually need them, but they're there as a backup and support for you because you're feeling like you're going to forget things or you're feeling less confident. Some people can't concentrate, and if you're in an open plan office, some people wear noise cancelling headphones so that they can get on with their work without being disturbed, and that can be quite useful if you really need to. And it's also important for most of these things to keep hydrated as well, so keep your water intake up, and that can help with your general headaches, etc., and just feeling generally unwell in the menopause. Next slide, please. So I'm going to look at some treatments now and different things that we can try. So I would say don't be afraid of HRT, but there are lots of other alternatives. So some of the alternatives, some herbal supplements may help you, some may not help you. You have to see what's suitable for you. Not everything that's a herb is natural and safe, so you do need to check what other medication you're on and discuss it with a pharmacist or your GP or your practice nurse or anyone else. So good interactions of things. So St. John's wort is good for anxiety and can help in menopause, but interacts with so many other things that you wouldn't want to take that without discussing it with someone else. And if you are going to try something, I would try one product at a time and make sure that you know what it is, you know what's in it, and try it for a good 3 months to see if it helps. If it doesn't help, move on to something else. Don't panic and panic buy off the shelves of a health food shop or off the shelves of a pharmacy and just buy everything they have, take them all at the same time, spend a lot of money, and then really not know what's going to help you. So I think one thing at a time and take it sensibly. And also, don't think if your friend says take this because it really helped me and you try and it doesn't help, that's absolutely fine. So it is individual and not everything will help everyone. Next slide, please. So it is important with alternatives that we know what's in them. So you do need to look for a herbal register mark so that we know what's in them. So we know that that is the right herb in that right tablet that you're going to take. What we don't often know is how does it work, and that's still sometimes research in progress, because a lot of the supplements are told as food supplements rather than medicines. So we're not sure how some of them work, but some of them obviously do work. There may be little evidence about them, so it's worth having a little look around as well to see how much they cost, because that can be more costly than HRT sometimes, or prescription medication. Does it interact with other medications? And that's particularly true for women that have had hormone-dependent cancers. Need to check that their medications are not going to interact with some of these herbs. And there is a very good fact sheet on the Women's Health Concern, which goes through some of the alternatives and whether they have any interactions or not. Next slide, please. So the NICE guidelines, which are being updated and will come out again soon, do suggest that there are some herbs that can be useful. They do say to look to make sure that they have the traditional herbal register logo on them, so you know they're pure herbs. They suggested things that worked which weren't medication or prescribed medication would be CBT, as I mentioned before, so cognitive behaviour therapy, can help for hot flushes and night sweats and for mood as well. Black cohosh was good for hot flushes, but possibly not so good for mood, and not as good as HRT, and they state the safety is unknown, although since that there has been several publications that suggest the safety is fine. So St John's wort, again, we don't recommend because of the interactions, but if you are taking nothing else, then you might like to try that for hot flushes. And then phytoestrogens. So these are plant forms of estrogen. If you sprinkle a little bit of soy on your cereal in the morning, it's probably not going to be very effective. You need to take quite a large amount of it. And not everyone is able to extract the ingredients from it that's needed as well. So some people just can have as much soy as they want and it doesn't make any difference at all. So it's far better if you're going to go for plant estrogens to take them in a commercial tablet, something like red clover, which is the dosage that you need without having to eat. And I think from listening to Kathy's talk at the BMS, was it 10 cups of chickpeas to get the same equivalent to a red clover tablet, which I think would probably make someone feel quite bloated and quite uncomfortable. So there is an equivalent that you need to do. Sage can be quite useful as well. So some people find that sage can help with hot flushes. And acupuncture. So acupuncture, the studies were mixed, as they are with lots of things. However, women did say they felt better. Their overall well-being was better with that. And it may be about sometimes some of the therapies like acupuncture and homeopathy and aromatherapy. It's time with you and a therapist, time to talk about you before having the therapy as well. So it may be a combination of the actual therapy and the me time that might help with that. So there are all sorts of things out there, and it is worth having a look around and seeing what's there, and then seeing if there is any evidence about anything. And there will be some evidence somewhere about whether they work or whether they don't work at all. Most of the alternatives, though, with the exception of most of the alternatives are looking at hot flushes and night sweats, possibly some with mood as well. They're not really looking at vaginal issues. They're also then not really be looking at bone and heart health too. So they are good if you have some menopausal symptoms, but not quite extreme menopausal symptoms, or a multiple presentation of lots of different symptoms affecting all over the body. Next slide, please. So special considerations, or when to go for help. So I was thinking about when to go for help, and I think firstly, when you want to discuss need or would like to have HRT. So that would be one indication. If you've thought about things, you've tried other things, you've looked around and you think, I think HRT is for me, that would be when to go to help. Kathy mentioned women that have menopause under the age of 40, so premature ovarian insufficiency. Definitely if your periods stop under the age of 40, you need to go and see someone for help, and you need to go and see someone for a diagnosis, and then make sure that you get the correct treatment. So that's someone that definitely does. If you've had cancer and you've got menopausal symptoms, then you may may need to go and speak to someone again, and probably not self-medicate so much because of the interactions. And again, with some medical conditions, you may need to go and speak to someone about the menopause and what you could do. Symptoms that you can't manage, or symptoms that are affecting your daily life or mental health, I would suggest that if you're at that point, then you should go and speak to someone. If you want to discuss testosterone, and that's been in the news quite a lot with Davina as well, testosterone may help, and I'm going to cover that slightly in a moment, but you might need to go and speak to someone then as well. And if you feel that HRT isn't working for you, or you've tried it and you really don't think it's for you, then it's obviously worth going to speak to someone again then. So next slide, please. So other points that I thought that would be useful for when to go for help. So red flags that come up. So postmenopausal bleeding. So if you have any bleeding when your periods are finished, or if you're having irregular bleeding while you're on HRT, it's worth going to speak to someone then, definitely. If you're having recurrent urinary infections, that could be a point when you want to go. Any vulval itching, changes in your bowel habit, bloating, unintentional weight loss. I put weight loss down first and thought everyone wants weight loss, so I put the unintentional. So if you've unintentionally lost weight, if you have any breast lumps, if you have palpitations that you're worried about, because they can be there with some hot flushes and stuff, but sometimes we need to check out that these aren't related to your heart as well. If your HRT is not working, or if you have a fracture, these were the points that I was thinking that you should really go and see someone fairly urgently and talk about what's happening with you. Next slide, please. So if you can't take HRT, there are very few women that can't or don't want to take HRT. There are some second line treatments. So you should never go to your GP and sit down and be offered these as the first line. These are second line treatments that you can be offered. So one of them is clonidine, which is a medication originally for blood pressure and is licensed for hot flushes and night sweats in women with menopausal symptoms. It can't be given with other blood pressure medications. It works in some women, so about 30% of women that take it, so not a great deal, and it can cause side effects, so dizziness and poor sleep, etc. So it may not be ideal for everyone, but it can be tried. We have a group of antidepressants that can be given, and they're not being given because menopause women are depressed. They're being given because the side effect of them and the way they work, it can help with hot flushes and night sweats, and obviously mood in some people. So some of them we would have cautions with if people were having breast cancer treatment and anticoagulants, but otherwise you can be given those. They work in about 50% of people that take them, but they do have side effects, and they can be nausea, dry mouth, constipation, and decreased sex drive. So not for everyone. We can use gabapentin and pregabalin, and again used as a side effect to help with hot flushes and night sweats, and obviously sometimes for pain as well, for joint pain, but again about 50% of people that take them find them okay, but they do have some side effects. And then lastly, we've got oxybutynin, which is originally a bladder medication, and again that can help sort of 60-70% of people with hot flushes and night sweats, so it's quite useful to use, but does have some side effects, and we have a caution if with cognitive impairment as well around that one. Next slide, please. So moving on to HRT, so hormone replacement therapy. So if obviously is a treatment, and it's a treatment for menopausal symptoms, and will help with all of the menopausal symptoms. So that will be hot flushes through to joint pain, protecting the heart, protecting the bones, etc. So next slide, please. So HRT is defined by the content, so what hormone is in it. So we have two different types. One is just estrogen only. So if you've had a hysterectomy and there's no womb, then you can have estrogen only. And then if you haven't had a hysterectomy, you need to have two hormones, which is estrogen and progesterone. Progesterone is there to protect the lining of the womb. And then how it's delivered. So it's either delivered orally as a tablet or transdermally through the skin as a spray, a patch, or a gel, or the progesterone component can be delivered intrauterine, so with a Mirena system, that's a hormone device that sits inside the womb. If someone is perimenopausal, then they start on an HRT where they will be given a sequential regime, so 2 weeks of estrogen, 2 weeks of estrogen, progesterone, and then a bleed, or a withdrawal bleed. And if they're postmenopausal, so no period for a year, continuous regime, so no bleeding. So they're the ways that it can be taken. It's generally, if you have estrogen only, you have a less risk of breast cancer, as that is one of the side effects or risks of HRT. There has been a lot of issues with supply, and I'm sure many of you on the call will have had issues with supply. So we had no patches last year, and then everyone switched on to gel or the spray, and then there's been no gel and spray this year, so everyone's back on patches. So it can be quite difficult. So you can have a combination of different HRTs as well, and you can just have vaginal HRT, which I'll talk about in a moment. It's important to say it's not static. So what you start off with if you start HRT in your perimenopause will be different to what you finish with if you carry on taking HRT into your 60s or 70s. It isn't static, and it may be that you might need to try a couple of HRTs before you find the one that's right for you, exactly the same as possibly you might have done when you tried the combined oral contraceptive pill. And then there's the issue of prescription charges, which hopefully is going to be resolved fairly soon. Some of them have 2 prescription charges and the frequency at which you're having to pay them as well. So hopefully that will be resolved fairly soon. Next slide, please. So HRT, what does it help with? So the estrogen in it does help with the hot flushes, the night sweats, the mood changes, can help with some sex drive as well. If it's given vaginally, it can help with the atrophic vaginal dryness, pain with sex, and also some of the bladder issues. Progesterone is given purely to protect the lining of the womb from estrogen, because if we didn't, it can overgrow and then you can get bleeding problems and something called hyperplasia. Some progesterone, so one of them, Utogestan, which is a micronized progesterone, can help with sleep if taken orally as well, so it may have an added benefit there. And then testosterone, which we do give to some people for mainly decreased sex drive, although some women do report it helps with their mood and their lack of energy as well. Next slide, please. So this is just to show the range of how things are given, so either as gels or as tablets or as patches, and also to add in there that there is a vaginal pessary, which is made from DHEA, which is can be used for some people if the vaginal estrogen doesn't work. So that's a precursor to testosterone, then precursor to estrogen. So we have lots of different options and lots of different ways of giving it. Some of them will be together in a commercially made product. Otherwise, we might give a gel and the Utogestan, or the gel and the Mirena. So some things will be individually, but some things will be available in a commercial product as well. Next slide, please. So testosterone at the moment is quite tricky because it's mentioned in NICE that testosterone for low sex drive, if HRT alone, is not effective. However, there's no licensed testosterone preparations in the UK currently for women, which makes it quite difficult for prescribing. Most areas have a restriction on it, so it needs to be prescribed by a specialist, and that's so that normally needs to be a specialist in primary care or secondary care. So there are testosterone products around, and what we tend to do is make a calculation about using them for a woman rather than a man. So it's normally a smaller amount. There is Androfen, which is a private prescription designed for women from Australia, but that's not on the BNF yet. So women can try testosterone. We do need to make sure that if we're trying testosterone, that we need to make sure that women have adequate estrogen or adequate HRT, normally in a transdermal, and that they haven't got any problems with vaginal dryness as well, and that explore a little bit around the sex drive and the libido issues to see whether it's going to be effective or not, because not everything related to sex drive is related to menopause. Next slide, please. So, as I've said, you can use treatments for vaginal dryness and painful sex. And this isn't just, I put vaginal dryness and painful sex because they are 2 separate things. So some women have very painful vaginas and vulvas that they can find uncomfortable sitting down or walking around as well. So it's important to unlink them. It's just that you need this if you want to have sex. So we can give vaginal estrogens, which is a very low dose of hormones, either in a pessary, a cream, or a ring, and they can be given the pessary and the rings, and the ring is a longer term one, but the pessaries and the creams and the tablets are every night for 2 weeks and twice a week after that. They have very low side effects and almost a no risk of causing any of the cancers that you read about with HRTs. You can also use vaginal moisturisers. So yes, have a range of vaginal moisturisers. It's important to get ones that are not going to cause irritation or uncomfortableness as well. So they can be used with or without vaginal estrogen, and vaginal estrogen can be used by most women without any adverse effects. Next slide, please. Breast cancer is the big thing that comes up all the time, and I know this chart is slightly old, but it does put into context some of the risks of breast cancer. So with HRT, an additional 4 cases of breast cancer on combined HRT taken for 5 years plus on women over 50. But then we look down, and then the pill gives the same additional 4. Drinking alcohol gives a slight more. Being overweight gives much more risk of breast cancer, but doing some exercise decreases that risk of breast cancer. So it is important to put it into context with all the other health risks that are going on and looking at you as an individual rather than just thinking, oh, it increases breast cancer in everyone, so therefore I shouldn't take it. Next slide, please. So finally, just a couple of myths. HRT causes breast cancer. Well, we're getting to know more and more. There is an increased risk of breast cancer with combined HRTs, but it may be slightly different depending on what regime you're on. So there is a slight increased risk of breast cancer, but a lot of other things are implicated in breast cancer as well. So it's not so straightforward. Breast cancer causes blood clots, and if you're using a gel or a patch or the spray, so anything transdermal, that doesn't have an increased risk of blood clotting. HRT is dangerous, which is one of the favourite headlines in some of the newspapers. Not particularly. It's a medication, so if it's given to the right person for the right thing with a full medical consultation, it's no more dangerous than taking anything else. It doesn't cause weight gain. The menopause itself might have a role to play in that. It's not a contraceptive, so it's important to remember contraception around this time as well, because as Kathy was saying about healthy living into the post your menopause, you don't equally want to have healthy living with a baby if you didn't really want to get pregnant. So very important to remember that. Natural methods may be safer, but they may not be safer for you. So important again to go back and get that. And you can only take it for 5 years, which is not true. You can take HRT for as long as you need to for the symptoms you've got, having regular yearly reviews. Next slide, please. So the other ones that come to clinic that I see quite often is you have to have stopped your periods to take HRT, which is so untrue. You can start HRT in the peri-menopause, so when you're still having periods, even if there's gaps in between them or so, but if you've got symptoms, you certainly can start taking HRT at that time. You don't always have to have a period on HRT, so once you go into the post-menopause, you can have a combined, continuous combined preparation, so there's no periods at all on there. HRT delays the menopause, which isn't true. So some people think if you take it for 5 years, then when you stop it, all your symptoms are just stored up somewhere in your body and then they come flooding out when you stop taking it. If you stop taking HRT and you still have those symptoms, you would still have had those symptoms at that point anyway. It doesn't delay it or push it on or anything. So the symptoms will carry on. It doesn't just cover up the symptoms, as I said, it doesn't delay anything. Vaginal estrogen has so much less risks than systemic estrogen. So if you use vaginal estrogen, if you've just got vaginal dryness or you've got some issues with the vagina and you just want to use that, using a year's worth of vaginal estrogen is the same as using a 1 milligram, so 1 tablet of HRT daily. So if you had 1 tablet today and then you use vaginal estrogen for the rest of the year, that's the same doses that you get in your body. So it's such a low dose. And women don't need testosterone because it's a male hormone. So there are certain women that do more than others, particularly women that have had their ovaries removed for surgical indications would benefit for some testosterone, and women that have problems with sex drive. Next slide, please. RCN publications, so I'll promote them there. We've got some clinical pages, so if you want to look on there, there's all sorts of clinical stuff on there, not only on menopause, but as we're on menopause, we'll talk about that. There's menopause at work, menopause and mental health, and then how to be a specialist as well. We've got our pocket guides there. And also, if people are interested in doing some training, Silk does give an educational bursary for nurses as well. So the website address is on there. Next slide, please. Other places I'd point people to would be Daisy Network for women with a menopause under 40, Menopause Matters, Women's Health Concern, and the BMS, the British Menopause Society for Professionals. Really good fact sheets on there if you want to know anything. Thank you.
Thank you, Deborah. I think I just need to switch me into live. Colleagues can hear me? Yeah. Yeah, so thank you, Deborah. Thank you both, Kathy and Deborah, we've posted the link to the research in the chat, so you can access that. We're now going to break for a short comfort break and welcome everybody back in 5 minutes. Thank you. Hi everyone, welcome back. We've had a really busy, detailed, informative couple of sessions from Kathy and Deborah. I can see that the chat box is starting to really come alive. Loads to go through in the panel, but our next session is menopause and mental health, something that was spoken to by both of our former guest speakers. So I welcome Kate and Rachel. If you could introduce yourselves, maybe we invite Kate first and then Rachel.
Thanks, Jackie. My name's Kate Bunyan. I'm the medical director for Stella, a behavioural change menopause app that we'll talk a little bit more about as we go through. And I'll start off the session and then I can bring us to Rachel, who can then introduce herself as well. So if I can start with our first slide. As everybody's been talking about, menopause is complicated and menopause has a huge amount connected with our mental health. And we thought one of the ways that we could help to bring this to life was to anchor it around a bit of a case study. So we'd like to introduce you to Sarah. So Sarah's a nurse, she's 48 years old, and her periods have been a bit irregular for a while, but you know what, life's busy and she doesn't plot them. So are they irregular or just, I'm not quite sure how long it might have been going on for, but it just doesn't feel like it's quite like it used to be. She also describes having night sweats and insomnia, and she used to be a great sleeper, but you know, it's the summer and it's hot. It's been really hot recently, but also, you know, life's busy, work has been horrendous. And there's lots of reasons why maybe I'm not sleeping as well as I used to. Sarah's feeling easily overwhelmed and stressed, but again, who can blame her? Work has just been incredible in terms of the pressure that we've been experiencing recently within healthcare. And when I think about how understaffed groups are, then that stress and that overwhelm that people feel, that seems to be the go-to place for everyone at the moment. So that's not unusual, is it? And with all that, Sarah's feeling really low in mood, but although there doesn't seem to be a particular cause, there's not been some life event that has brought her mental health into question. Things just don't feel right. But she's also forgetting words. She's forgetting the conversations that she's had, and that's coming back at her in her work environment and really starting to give her cause to doubt her ability to perform at work. And this is an example of a scenario that we encounter all the time. And, you know, I could tell this story about myself. So how would we take this forward? Sarah's got to the point where she just knows that this is not going to work for her, because now she's really anxious about whether she can in fact still hold down the jobs that she has. So Rachel, can I hand over to you and get you to introduce yourself and then talk us through what a consultation should look like in relation to Sarah's symptoms?
Hi, so thank you, Kate. Hi everyone, my name's Rachel Hines. I'm a menopause specialist and a GP specialising in women's health and spend a lot of my time doing menopausal consultations. So in terms of what the consultation would look like, so you'd want to, first of all, you need to take a full history of all her symptoms, so trying to elicit how long she's noticed a change in her periods, if she's noticing any other symptoms as well that haven't already been mentioned. You'd want to know if she's having any physical symptoms, so if she's been having any weight loss or palpitations. It's just explore and see if there's anything further around in terms of the moods, the symptoms that she's been describing. And you just want to do a bit of a systems review and just finding out what her main concerns are, and most importantly, how these symptoms are impacting and how they're affecting her. I'd also want to explore if there's anything going on at home, if there's anything going on at work, if she's noticed any particular triggers that could be contributing to the way she's been feeling. I'd want to explore lifestyle, so finding out if she smokes, how much alcohol she drinks, if she does any exercise, and if she gets any time for herself, which is quite important to think about as well. And then would be seeing if any lifestyle modifications can be made that could help with menopausal symptoms, but then would also be exploring what treatment might be appropriate for her. So consider finding out if she's tried anything already, if she's tried anything over the counter, thinking about if hormone replacement therapy would be helpful and could explore that further with her. And also thinking about other options, including CBT or other relaxation, different methods like that. Handing back to Kate.
Thanks, Rachel.
Sorry.
So menopause and mental health is going to go back to Rachel, please.
It's going to go back to me. Apologies. So just, if we could have the next slide, please. So thinking more widely about the impact of menopause and mental health. So we know that hormonal fluctuations can impact on mental health in the perimenopause and menopause, but it often can be some of the earliest symptoms that show in the perimenopause and sometimes without any other menopausal symptoms. So it can include a wide range, but it can be suffering from low mood, depression, irritability. Lots of women describe having a feeling of rage or just getting really angry at for something seemingly innocuous, or having a really short fuse and just losing their temper very quickly. You can feel anxious, it can be intermittent anxiety, or it can be all the time. And many women describe feeling very easily overwhelmed by things that previously wouldn't have concerned them. There can be cognitive symptoms as well, so brain fog, memory problems and concentration problems. And another symptom can be fatigue, which, especially if you've had bloods done, if there's no other cause for, fatigue can have quite an overwhelming impact in addition or to these other symptoms as well. So I think Kate will carry on. Thank you.
And next slide, please. So how does menopause and mental health in the workplace fit together? So we've talked you through some typical symptoms. We've talked you through the impact they can have. But I think all of us recognise that those are symptoms that we can feel because of so many other reasons related to work. So menopause in the workplace is such an important area for us to try and get right, because the impact on our work, from feeling overwhelmed, from not feeling like we can manage workloads, from feeling that it's difficult to learn new skills, the loss of confidence in presenting or speaking in public, even just speaking in amongst your peer group, maybe at handover, the brain fog and trying to get yourself through all the things that you used to just take in your stride. And that, combined with the physical impact of work, the long hours, standing, lifting, physical environment, this can be really debilitating because you start just questioning yourself. It's so much easier to look internally at why am I failing to be able to do this, than to sometimes be able to recognise that this is all about your hormones. And because it can happen at a variety of different ages, last for a variety of lengths of times, it's not so straightforward as to say, right, I've hit that point in my life. And it can be very difficult for us to say, well, actually, even though I'm a healthcare professional and I should know about these things, and yet we miss it entirely because we've got loads of other good reasons to put all these things down to. And I think that's one of the key reasons why thinking about our mental health and finding ways of connecting that to menopause and using that as one of the first go-tos when you start feeling these collection of symptoms, even without the typical hot flushes, just as Kathy said in the beginning of her session. We have those characteristic physical symptoms, but these mental health symptoms can often be so debilitating and can often precede some of those physical symptoms. So being willing to and open to having conversations at work about how you're feeling without feeling like you are having to declare to people that you don't think you can cope with your job anymore, I think is really important. Because one of the challenges for women approaching menopause is often you're also at the peak of your career. You have got huge amounts of responsibility. You're taking on lots, both in work and outside work, and it all comes together at the same time. So just when you want to be at the top of your game, your hormones start letting you down and you start feeling that maybe it's you. And what we're really looking for is for workplaces to be able to support people to say, no, we can support you, because it's all about how we get the best out of everybody at all stages of their life and career, and not letting this be the reason why we lose people's confidence, or lose people's willingness to just step forward and continue to engage at the level that you're doing at the moment, because there is help available. Next slide, please. So Rachel, what sort of help is available? What can people do for themselves? And then what can also we can be thinking about workplaces could be doing?
The changes that you can implement yourself. So sleep hygiene is really important. There's a wealth of information about it, but trying to help improve sleep can have a really significant impact on mental health. So basics include things like going to bed at the same time each night, making sure in an ideal world that your room is cool in the evening, but having a sort of constant temperature, not using your phone for an hour or two before bed, not exercising late in the evening or having caffeine in the evening, but implementing changes that you can do to try and help improve sleep is really important. Regular activity and exercise is important. It's really helpful for your mental health. It can also help with sleep as well. But so doing regular cardiovascular exercise, making sure it's something that you enjoy, but that helps with endorphin release and can help support mental health. Finding time to relax, which I know is easier said than done, but again is something, if you're able to factor it into your week, is really important. Cognitive behavioural therapy helps with mental health, so both menopausal and non-menopausal, but we know that it helps with mental health symptoms in the menopause. So if you're able to refer yourself for that through your GP or through work, it's always something that's worth exploring. And also there's lots of online help as well. Stella has a cognitive program, which Kate will tell you more about, but there are lots of different apps that help. Hormone replacement therapy can be really beneficial in treating mental health symptoms, and you usually see a really significant improvement when you start taking that. And the other thing that we do use are antidepressants. Lots of people often speak very negatively, saying that they were only offered antidepressants, and sometimes that is because the only symptoms that are being presented with are mental health symptoms, particularly in early perimenopause. But antidepressants do play an important role, and particularly if you've started HRT, if your other menopausal symptoms have settled and you're still experiencing anxiety or low mood, then antidepressants do play a really important role in treatment. So, back to Kate.
So next slide. You're about to have a brilliant panel discussion with some real experts in this area to talk about how the workplace can help support around menopause. And it's really important that we do this as a whole workplace phenomena. So in occupational health, sharing your concerns, thinking about your environment and how policies can help underpin this. But none of this is easy, and we get that. What you can do for yourself is really key too. And we're delighted that Stella is an app that you can make use of that covers behavioural change, because sometimes you just need that help to get into these new rhythms, just as everybody's been saying. It's about overall wellness and well-being, fitness for the future. And sometimes we all just need a bit of a helping hand with how we can do that. You'll be getting some more information after the session about how you can make use of Stella, but we're delighted to be able to offer all the nurses that are involved in this call a year's access through the voucher code that you can see on screen, and you'll get that coming through to you as well. So thank you ever so much for coming and joining this session, because I think the more we all talk about menopause, the workplace, and how we can really make a difference in our workplaces, the more likely we are to make it much easier for women to go through the menopause as successfully as they can do. So thank you very much.
Thank you, Kate. Thank you, Rachel. Another perspective around menopause that we hear very frequently. So we're going to move into our panel discussion. And I note that Paula Stewart, who is a menopause and lifestyle coach and learning disabilities nurse, is actually working in the chat box with questions. So Paula is doing a grand job through the chat box, and we'll pick those up. I think there were some IT issues, some access issues. So just to go through our panel, we have Kathy Abernethy, who we've heard from today. We have Cherry, is it Kerry or Cherry Feldbauer?
It's Kerry Feldbauer.
Kerry, and welcome, Kerry. And as I've mentioned, Paula and Pamela Windle, Women's Health Coach from My Sisters too. Welcome all. So I'm going to work through the chat box and bring together some of the themes and questions. One of the first things I wanted to draw out of the chat, and perhaps a question for Kathy. As we mentioned, NHS England has been, I'm really thrilled to say, quite pioneering for the NHS in some ways in rolling out. We commissioned Pepi Health for our staff, and that's a self-referral access, and rightly so, because it speaks to some of the issues we've mentioned around gender recognition and that conversation that can be deeply sensitive to line managers. So we have a few comments in here about, does menopause fall under the remit of the Equality Act, and also some aspects of feeling as a nurse we're expected to cope, and some of those other aspects. And one of the biggest feedback pieces we had from both our early trial work with Pepi and then into commissioning and evaluation in the early days was that sense of having somebody walk beside me, but then being able to holistically assess but hone in on my menopause and my journey. So could we maybe pick some of those themes up to answer a number of themes?
Thanks, Jackie. I mean, I'll start with the question that was asked about is menopause, does it fit under the equality remit? I mean, yes, it does, but it's not explicit. And there's been a lot of debate in the Houses of Parliament as to whether it should be one of the factors which is explicit, like we have race and gender, for example, and age as being explicit. But menopause fits into so many other parts that it's certainly, we have to abide by the law, and it already fits into regulations that we have within those other policies. But sometimes it can be difficult to understand how it fits in, but it does. In answer to your second question about coming alongside, that's exactly what people want. You're absolutely right. You know, when I was working, I worked for 30 years in the NHS in a menopause clinic, as Deborah does as well. And the patients that we see say to us, you've just changed my life by just being alongside me. But in the NHS, I could only do that for a small number of people. But when you're helping somebody, when we did NHS England, an improvement project, for example, with you, Jackie, we were helping lots of women alongside with real practitioners, real tangible support, so that then they could make the changes that were right for them. And there was no one way that they all did the same thing. You know, we came alongside them, we explored the options, we helped them to make the choices, and then we helped to direct them to make those choices in an easy way.
Thank you. Thanks, Kathy. So there's a number of other questions here around workplace recognition and driving that forward. And this might be something we pick up between Kerry and Pamela. I'd welcome your thoughts on this. Perhaps Pamela first, in terms of difficult conversations with managers not recognising this as an issue that needs that support.
Yes, hi Jackie. Thank you for that question. So absolutely, this is something that needs to be brought up, and we can see that, as of 2018, there's been a rise in women, seeking lawsuits against employers. So it's a definite conversation that we need to have. And so, as a line manager, senior leader, they need to be educated. They need to understand what's going on in a woman's life. They don't need to be an expert in it, but they need to understand what's going on, what is the real cause of their discomfort in the workplace, what's the domino effect, and then how they can have an authentic conversation with that woman and she feels safe in the workplace. Because if a line manager is male, or even a younger woman, or another woman that's gone through the menopause, but hers, for example, was easy, and this is woman sat opposite you and she's having a really dreadful time, then there's going to be a discourse there, isn't there? So it's about understanding, taking that woman, the face value of how she's experienced, and then how you can help women in the workplace to have an easier journey. And I think it's a modern workplace. A modern workplace is supportive and inclusive of all women.
Thank you. Kerry, do you want to come in on that in terms of how we achieve not only awareness and obviously as we've spoken to the fact that this is still taboo, and that we know there are often media images are of a white middle class woman holding a fan. This is prevailing issues that we're breaking down, but we have to start with the person themselves to maybe have that conversation, to be able to make this a thing at work. But then if the workplace doesn't pick it up, there's an aspect of are we lagging in a transformational sense?
Definitely. I'm so pleased to be able to just sort of come and share our experience at Sherwood Forest Hospitals, and I think that my observations around this is that you can have as many offers as you like in terms of support for colleagues who are going through the sort of menopausal symptoms. But if you don't have, and when I sort of speak about leaders, I mean, I don't mean hierarchical, I mean sort of influencers within your organisation who are willing to talk openly about it and to keep that consistent message. And we had Suzanne Banks, who was our chief nurse, and that's where really our journey started 3 or 4 years ago, where, going through the sort of symptoms herself, she would be constantly referencing it at meetings, making sure that her environment was really comfortable to be able to sort of do the best that she could from that meeting and in that sort of scene, and that really pervaded the rest of the organisation in terms of that psychological safety, in that terms of that sort of support to be able to have those conversations without taboo. So I think that sort of, yes, have the offers, but making sure that people feel that they're not in a room, they're in a village with a lot of other people going through the sort of same and incredibly unique journeys in this. But by having those conversations and creating spaces for people to have those conversations and keeping it visible, I think is really important.
Yes, yeah, indeed, and having that, I think that is really important, and having perhaps a senior champion in the organisation helps some of that purchase around a topic like menopause and helps things change. So one of the other things that's coming through is diet. Any takers for dietary aspects? It does seem to be quite a popular theme there. Weight gain overnight is a horror of menopause. Anybody want to particularly take that? Yeah, Pamela.
Yeah, so weight gain is a problem in that perimenopause and menopause, postmenopausal woman, but it doesn't have to be. And, you know, having had over 20 years experience within the health and wellness industry, you know, the model for weight loss is to eat less and move more. And actually, that isn't conducive for us as women in general, to be honest, but particularly for the women who's 40 plus, who is in that perimenopausal field and postmenopause. In actual fact, we need to eat more. When I say eat more, we need to eat more of the good stuff, more healthy fats, more protein, more fiber, more antioxidants. And we need to move less, but smart. So the research is, you know, really skewed, isn't it, around this? It's still got a long way to go when it comes to understanding women's health. But so far, what we understand is that actually women do better with weight training and also something like HIIT training. So that's like high intensity interval training, which is sharp, but it really intense, rather than this long, you know, duration exercise like running for half an hour on the treadmill, or doing aerobic classes, or doing body pump, for example. So doing really high intensity exercise, but for a short period of time. And then when it comes to diet, and I really don't like the word diet because it sounds restrictive, you know, it's about taking things out. Don't eat fats, don't eat this, don't eat that. But actually, if you start to put good foods in, and Debbie did talk about some herbs. Herbs are super powerful, that actually help women. And so it's about balancing your blood sugar levels. Unfortunately for us as women, as our estrogen starts to withdraw, we get the two ugly sisters, that I like to call them. The two ugly systems is insulin and cortisol, and they kind of rise, and it's those two that we need to start managing. And when we do that, that's when we start to lose weight without restriction. We're not dieting, it just comes off naturally, but it is possible.
Thank you. Thanks for that, Pamela. Okay, another theme, perhaps this is one for you, Kathy. GP confidence in managing HRT, and there's a raft of comments ranging from "you're too young" to "no, I'm not happy to prescribe it" to "you can't have it" for various things like clots, and even to the question, can you actually ask your GP for HRT? So could we explore those aspects, but also where we are with GP training?
Yeah, certainly. I mean, this is close to my heart as well, because as part of the British Menopause Society, we set standards of care for menopause. And believe me, our courses for GPs are oversubscribed every single time. So it's not that there's no GPs that are interested, because there certainly are a raft of GPs who are excellent and really want to learn more. But the resources haven't always been there. That's the first thing. But also, we're living with a generation of GPs who are still remembering the old days, if you like. They're still remembering when hormone replacement therapy was considered to be less safe than it is these days. And like all of us, you know, have they kept up with their CPD is the question. Well, sadly, not all of them have. And so they sometimes give advice which is a little bit out of date. I think one of the other things, Jackie, that I get irritated about is that there's no other area of medicine where we take a personal opinion. You know, if you're diagnosed with diabetes or thyroid disease or cancer, you won't hear anybody saying to you, well, I think the best thing is this. What you'll be heard is this is the evidence base and this is what you should do. And I think it's time as healthcare professionals that we start passing that message on to those who are experiencing symptoms. So even if you wouldn't take HRT as a GP, or even if you don't believe it's the right treatment, you should be presenting the evidence for choice for the person in front of you. So somebody said, you know, is it okay to ask for HRT? Yes, absolutely, it's okay to ask for HRT, but there is a way of doing it. So one of the articles that we have on the Pepi app, for example, is getting the best from your GP. So you want to make sure that, first of all, you're choosing the right GP. There will be a GP in the practice who is a little bit more interested in menopause and women's health than someone else who might be a bit more interested in child health, for example. So choose the right GP. And if you're not sure how to do that, my tip for you is ask the receptionist, because they have a pretty shrewd idea as to who to ask. And then secondly, prepare really well for your consultation. So it may be that your first opening sentence will direct that consultation. So if you go into the consultation saying, well, I'm not sure if I'm in menopause, I don't know quite what I want to do about it, you've only got 8 minutes to get a decision. Whereas if you go opening your conversation saying, I've done lots of research, I've read around the evidence, I'm confident about my symptoms and I would like HRT, you're much more likely to end up on it. GP training, just to go back to that, there's a wealth of training about there. There is that saying that you can take a horse to water, you can't make it drink. There is a huge amount of education. It's not that there isn't any, it's just that unfortunately, like nurses, like other healthcare professionals, they don't always choose to avail themselves of it. Jackie?
Can I just add that slightly, Jackie, in regard to HRT? So obviously I'm seeing ladies now that are coming in who are on HRT, and you know the GP's prescribed HRT and they're taking more and more levels of HRT because they're still struggling with the fatigue, the brain fog, the mood swings, energy problems, but they're still having more and more HRT. And I think there needs to be more conversation around the holistic. It's not that you have to have HRT or you don't. It's about supporting that woman holistically, regardless if she's taking HRT or not. And so when we start to, and talking again about balancing blood sugar, when we start to balance blood sugar and we work on, supporting gut health, this is where we get the best out of that, whether you're taking HRT or not. And I just wanted to add that in as well into the conversation.
I think that's really important. I completely support that. And that's why there's no sort of one-stop shop for menopause. Your GP maybe is the place to go for medical treatment and they will give health advice. But actually, we need to look much more broadly than just our GPs. Jackie?
Yeah, yes, thank you both. Excellent points, and things that you can eat and drink yourself, like the gut health connection, like the food dietary connection as well, in your toolbox, so that you manage yourself as much. We've had a specific question around fibroids and HRT, Kathy. Obviously there are, sorry, I'm just asking if everybody could go on mute, please, if he's not speaking. Obviously there are unique and individual circumstances, but in general, the connection between HRT, fibroids, and perhaps would it rule somebody out?
So obviously we can't make individual medical advice here on this particular meeting, but generally speaking, if you've got fibroids which are not particularly troublesome, HRT is going to make them no worse. Occasionally, if you've got very, very large fibroids which are giving you heavy bleeding and so forth, then it's not the time to be starting HRT. You need treatment for the fibroids. And actually, Deborah Holloway is an absolute expert on this. So I'm going to throw this back to you, Deborah, to just expand on that a little bit more.
Thanks, Kathy. So yes, as Kathy said, if you've got some fibroids that have been quite stable, then I think HRT will be fine for them. What I will say is if you start HRT and you have got fibroids, they won't shrink like they would if you weren't taking the hormones, because the fibroids do have the estrogen, they like the estrogen, so it will keep them about the same size. If you have fibroids inside the lining of the womb, so one's called submucosal fibroids that can cause heavy bleeding, it would be worth getting those sorted before you started HRT, because otherwise you might get some irregular bleeding and then we don't know what's causing it, whether it's the fibroid or the HRT. And if you've got lots of fibroids, you might not be suitable for something like a Mirena inside your womb as well. So it does depend on the size, the location, and the number, and what they've been like all through your life. If they've been the sort that have been troublesome and causing lots of symptoms and keep growing, you might want to rethink it. But if it's been one or two and they've been quite static, then it shouldn't have an impact. So it is really individual, and it's worth getting someone to assess the scan and then go and talk to someone about it.
I'd like to add to that, if that's okay as well, Jacqueline. So obviously Afro-Caribbean women are more likely to have fibroids, and so then the white counterparts. So there's, from a lifestyle point of view and nutrition, there's so much you can do. If you don't want to go down the medical route, for example, eating lots of green leafy vegetables will really help to reduce that toxicity in the body, so you kind of reset the hormones slightly. And also toxins from the environment, things that you put on your skin as well, bind to your receptors of estrogen and will feed the the fibroids as well. So there's so much you can do from lifestyle and nutrition to help to re-regulate or to not shrink the fibroids, but stop them being problematic.
Thank you. I think we've got that covered. The next question is around the theme of changing the organisation, Kerry. So I wonder if there's any top tips you can share, things like everything from uniform policies. How can we get practical change for operational staff that are struggling? What sort of tips can you share that worked for you guys at Sherwood?
Yeah, absolutely. So I think it's sort of spray and pray. I think our approach, as we've got sort of, you know, so many different offers. You know, we've got the menopause guidance that was co-developed with colleagues and by our HR department, which just gives you that sort of reassurance, really, to have something that sort of shows the commitment to the organisation. We've got sort of e-training that people can access at any time to do with sort of joint pain, general menopause queries. We've got a menopause group that meet and sort of canvass opinions from across the organisation. From, you know, I've just been around the last week and it's been absolutely dreadful for people, especially sort of from our age group, going through these symptoms, having to cope with the heat in heavy uniforms. So we're sort of canvassing opinions. We've got a women's network that this, you know, with male allies as well, that this sort of feeds into. We have monthly drop-in sessions held at all different times of the day and evenings that people, if they've got a specific query, can do that. We've got menopause mindfulness sessions. We've got a fantastic occupational health service that, you know, are really, you know, open, and as somebody mentioned earlier, we can put ourselves on ESR with as and sort of show that we're going through the menopause. So so we've got sort of lots of different, and it is just going around having conversations with people about what would work for them. But absolutely, as you sort of said earlier, having a sort of senior sponsor for that is helpful. Somebody who's really passionate about it, and so that sort of helped us on our journey. And I think it is that sort of, you know, trying to make it, you know, knowing that people are working nights, people are on long days, how can we do little and often to keep it there so that people can access it sort of when they need to. So I think it's that sort of consistency of message that's important.
Certainly is, in my experience. Thank you, Kerry. The other addition to that is willfulness and bottom up change. So certainly in my experience, the change was absolutely underpinned by lived experience and asking, and then, you know, trying to be that example of change, just as you've said, just as you've outlined. Ask and then ask again, or, you know, be the supportive person to make it happen. So yeah, really good examples. I'm going to come back to Kathy. Perhaps this one's for you, Kathy, around the HRT prescriptions. Now, this will be part of the national programme, I would guess.
Yeah, so the government approved just before Christmas that HRT prescribing will be an annualised cost. And they made that lovely promise through Parliament that there would be a single prescription cost for 12 months. But of course, there was no funding for it. Usual idea without any follow through. So unfortunately, that has not yet happened, but it is planned to happen. So what will happen going forward? Probably it's going to be 2023 before this happens. But instead of having to pay a prescription charge every time you pick up your script, whenever that is, you'll be able to have a single prescription charge for the whole year. Doesn't mean you'll get your year's worth of prescription, because you might need to change it, but it means there'll just be one cost. And also, I'm hoping, I haven't got this in writing or confirmed, I'm hoping it'll be a single cost. So the same across the board, whether you're taking 1, 2 or 3 hormones. But that's all to be confirmed. It is good news. It's good news for those who are on prescriptions where their GPs will only give it to them every month, for example. Those costs really build up. We were also hoping that we'd get free prescriptions of HRT altogether in England, which we haven't got. It's low cost rather than free. Of course, in Wales and Scotland, they don't pay for prescriptions anyway, whether it's HRT or anything else. And then there's a whole issue with the younger people. You know, the cost is important to all ages, but it's particularly important to our young women who, if they were on contraception, would get it free. But because it's HRT they're on, they don't. And that's a real political issue that we're still fighting.
Certainly is. Probably a good question for Pamela, if I may. This is a tricky one, but will probably come to you wrapped in other ways. Low libido and struggles with your partner and your sense of self and intimacy. It was quite a popular one. Somebody very generously and very bravely put that on and outlined even the extent of being intimate, touching, or being cuddled, things like that with partners. That, aside from the actual clinical work, that must come through in a lot of coaching.
Yeah, so I mean, obviously it depends on that relationship. Does that woman want to be intimate with a partner in that way? And there are many different ways to be intimate, isn't there? It doesn't have to be sexual. So holding hands, for example, might not be the same as, being next to somebody naked. So it's about understanding where you are in your relationship as well. I guess the other side of it is that women, because they're gaining weight, they don't recognise their bodies, they don't like their bodies anymore. There's that discomfort between what they looked like prior and what they look like now. So coming to terms with how you look on a physical level might be quite hard for some women, and that could be then impacting their ability to, feel amorous, feel sexy, because they don't look sexy anymore, or the idea we perceive as what being sexy. And I think for that sort of woman is to get some coaching and also some therapy, and just don't sit with that on your own. It's about, sort of accepting where you are right now. Doesn't mean that you have to stay where you are, but just accepting where you are might be the start of the journey, so that you do then either lose a weight or you do accept that you're now this shape and you can have a physical relationship with your partner. But the other side of that, going on to the more physiological side of it, many women feel exhausted. So, why would you want to have sex if you're feeling exhausted? So let's work on building your resilience up first. Let's have a look at how your lifestyle, your work, how is that impacting you? If you're working shifts and your sleep hormone, for example, is all over the place, and you're indoors all day and you don't have any exposure to natural daylight, which is such an important thing to help us to make melatonin, our sleep hormone. Let's start with, okay, when you come home from your shift, maybe I'll sit outside for a little, and just absorb that natural daylight just throughout the day. So when it comes to being physically active with somebody on a sexual level, I guess it's understanding why. Why do you feel like that? Is it because of your self-esteem? Are you exhausted? Or is it a hormonal issue? Or is there something else going on? Maybe your thyroid is compromised. Maybe you're at risk of type 2 diabetes, or what's your cardiovascular health? So there's all sorts of things that we have to look at when it comes to women's health, whether you feel sexy or you want to have sex, it all comes into play. Thank you.
Thank you, Pamela. Rolling on from that, another interesting question. And another very generous question is about vaginal dryness and the impact of that when having or not having a sexual relationship, and how that can impact. I think this is also one of the topics that Pepi offers, Kathy. So quite another common theme that we hear. I wonder if that's a good one for you.
Thank you. Yes, it certainly is, because you don't always want to go and talk to your doctor about your vagina, do you? But if you can talk to a nurse who's going to listen to you and you can talk on an ongoing basis as things change. We can come alongside you and give all sorts of tips around moisturisers, lubricants and treatments like vaginal oestrogen if you want them. There are various options. I mean, you don't have to go straight for vaginal oestrogen, although, as Deborah said, vaginal oestrogen carries no risk. It's not associated with any of the risks of ordinary HRT. And the good news is, you may have seen yesterday that vaginal oestrogen is going to be available over the counter soon. So that's going to be a real step forward. It means women will be able to take control themselves and go and speak to a pharmacist in order to buy a medical treatment for their vaginal dryness. But if they don't want that, there's lots of other things you can do. You can use moisturisers, which are used on a regular basis. So they're not just at the point of sex. You think, oh, I'll just do this at the time of sex. But actually, you need to moisturise your vagina like you need to moisturise your face. So they say. So you have to use it on a regular basis, and it works by plumping up, if you like, the cells of the vaginal wall. Estrogen helps to regrow the vaginal wall. The cells are regenerated and turning over, whereas moisturisers will help to plump them up. It won't change the actual cells at all, but that helps. That really helps with comfort. And then at the time of sex, yes, nobody tells us that as you get older, you probably need a lube to help things along. And actually, it's perfectly normal to add that into your sex life with your partner, whether that's a man or a woman. You can involve that in your sex at the time of intercourse. And so it's bringing all those things together and mainly understanding that you don't have to just put up with it. It's such a common thing, and yet people don't want to talk about it. And I say we should be talking about it. And actually at Peri, it's going to be our main focus for October, is all around vaginal health.
Really, really important conversation. And I think that's true. A lot of people would feel perhaps less open in a timed session with a GP they know is very busy if they can get in there. They perhaps might have seen that person, perhaps it's their third appointment or maybe more, and they feel they're not equipped or confident enough to push that conversation to where they want it to go. So certainly a lot of my colleagues do prefer that one-to-one with their nurse that they build up a relationship with. There's a comment in about mood swings, irritability, not necessarily hot flushes, and would this warrant a trial of HRT? And we could all nod if that's how you want to go. So I wonder if there's any thoughts on trials of HRT. That may be another one for you, Kathy. Sorry.
That's okay, I'm happy to take it. I mean, I think the thing with the menopause is it's never one single symptom. It's usually a cluster of symptoms. And it's good to sort of try and work out which are the ones you want to tackle first. And something like flushes and sweat, for example, responds so quickly to HRT that if you've decided that now's the time to treat them, then HRT is the answer. But those other symptoms like memory loss, brain fog, concentration issues, sometimes they can be addressed by lifestyle changes as well. And I'm sure that Paula would be able to help here as well. That, you know, you can change through dietary changes, through mindfulness, through reducing your workload stress, all of those things. Yes, if you take HRT, it might help too, but it's not always the go-to for those symptoms.
I was going to say, actually, so the gut-brain axis, you know, the gut-brain connection is really important to think about. So, you know, how many of us have had antibiotics, for example? How many of us have drink alcohol and all of that, and have stress in our lives? All of that changes the ecosystem in our gut. And so, you know, women that are struggling with anxiety and depression, mood swings, sometimes it could be that the diversity in the gut is just not where we want it to be. And so when we support the gut with beneficial bacteria, probiotics, prebiotic, food, not necessary supplement, food. I always think food comes first. You know, that is where we then start to reduce those symptoms. And then, you know, like I said earlier, you know, that's when, if you want to go down the HRT route, that's when it kind of works for you much better. And even with hot flushes as well, it can be gut related or liver related. And once we start to support those with nutrition and lifestyle, then you might not need as much HRT as you were on originally, and it's, you know, it's going to work for you much more than, you know, than without those lifestyle and nutrition interventions.
Thank you, Pamela. I think we're also checking on your session, your individual session. So I will look through the further number of questions. So a key point that, another key point was that women don't feel they're listened to, and often carry on doing the doing, juggling spinning all the plates, and don't feel listened to and don't feel sometimes equipped. Somebody else in the chat actually took their husband with them to advocate for what they didn't feel able to kind of speak to in an appointment. So that's a key point there, is that invisibility, loss of sense of self, which I think we touched on earlier, and which exacerbates the anxiety and the kind of, you know, need for maybe support. I don't know whether that would be you, Pamela, or you, Kerry. Would that be?
I'm happy to go first on this, and you know, it's really interesting that this has absolutely happened to me in the last 2 weeks, where I have been coping and sort of paddling, and it takes something outside of your work environment, a family bereavement, something that completely tips you into that sort of recognition. And I think it comes back to that you know, that sort of statement right at the start, really, about being kind. And I've picked up lots of really helpful suggestions today about keeping a diary, about sort of tracking things. But sometimes you're at that sort of, you know, the water's pouring out of the spout before you sort of recognise that symptom. So I think that it is. So I don't think I've got any advice on that. I think it is just that sort of, you know, recognition that you know, that to seek help earlier. You know, and don't let yourself get to the point where sort of, you know, you think it's simple things can get sort of totally out of proportion. And I, you know, myself in my experiences, I've just had a conversation now with my line manager about feeling, you know, totally unconfident in my role and the impact that it's having on me in terms of that sort of speaking out at meetings. So I think just continue that dialogue, and it feels really uncomfortable, but you have to. If you don't do it and have those conversations, how many other people aren't having those conversations? And I think it's sort of, you know, that sort of, you know, it's this sort of responsibility on yourself to sort of recognize when you need support and need help, and to speak out about, you know, be courageous to speak out about it and help other people.
Yeah, and it is about spreading that message, sharing what you've learned, and you know, offering your knowledge and experience so that somebody can either take some of that or build it onto their own, because as we've said, it's all very unique, isn't it? But sharing that support. There's been a number of questions around symptoms management, things like specific things like hair thinning, like palpitations, irregular heartbeats. I wonder whether and we've gone through the symptoms, common symptoms, shall I say, in this session. So if I might just turn that theme a little bit into a question around how do you know your HRT is right, at the right dose, taken at the right time of the day, and is the right medication for you? How will you know you've got it right is a common kind of question I hear. perhaps that's back to you, Kathy.
Yes, I hear that question a lot as well. And you know, are you on the right HRT? The first question is, are you on the right HRT for the stage of your menopause? So if you're going through peri-menopause, still seeing periods, then you'll be on an HRT which is cyclical, as Deborah mentioned in her presentation. If you're starting HRT soon after the menopause, maybe you've not seen a period for 12 months, then you'll be on a continuous HRT. So are you on the right type of HRT for where you are? That's the first thing. Secondly, are you on the right dose? Well, you want to be on the dose which does the job. So that may not be the lowest possible dose. It may be that if you're quite young, you need higher doses. And if your symptoms are quite bad, you might need higher doses. So is it working is the next question to help you decide that. And then finally, do you feel that you're back to normal? That's what we're aiming for on HRT, is simply to be back to normal. We're not giving everybody a new lease of life. You know, you're still going through aging, we're still going through work pressures and everything, but you know, is it helping you to get back to normal? And if it isn't, then I think that's the time to look not just at your HRT, but all those other things that Pamela was talking about as well.
Oh, thank you, Jackie. I just got some slides that I just wanted to share. I don't know if you've seen that.
No, that's I think we were waiting to see to load, yeah, and go through. Sorry, Pamela.
Okay.
I think we've covered a vast number of themes, so I will hand over to you and we'll take it away.
Thank you. If you could pop slide number 5 up, that would be great. So while you're doing that, I just wanted to say that this is a fantastic conversation, and we also need to be talking about, you know, different cultures and how it affects different cultures and menopause in the workplace. You know, many cultures don't even talk about it amongst themselves. You know, the African Caribbean and the Asian culture don't actually talk about their menopause or perimenopause, and I think that needs to be a subject that happens in the workplace as well. So I just wanted to draw your attention to the HPA axis, and I think it's really important to understand this. So everything that we've talked about, things that Kathy said, things that Deborah said, things that were said before, you know, this is a really really important thing that we need to understand, because when we're talking about doing yoga or meditation, often people will disconnect. Well, why should I do that? And this kind of brings it all together of why we need to take those approaches. So the HPA axis is the hypothalamus, pituitary gland, adrenal axis, and the rest of the axis is like your ovaries, which includes the pancreas as well, the thyroid, and it's a feedback to the body to tell us that the body is in a state of stress. So the hypothalamus regulates our body temperature, but it also modulates stress as well. And so when we are in stress, it sends a signal to the pituitary gland, and the pituitary gland also has a direct relationship with your ovaries. And then there's a cascade of stress-relating hormones that goes to the adrenal glands, and the adrenal glands also produce your sex hormones, particularly post-menopause as well. So the lady that was talking about libido, maybe your adrenal glands, you know, just a bit sluggish and need a little of attention, or you need to manage stress, let's say, rather than just target the adrenal glands. And so what is stress? Well, stress could be a perceived thought, something about worrying about something that might never happen, or going over something that's happened in the past that you've not actually got some support from. So you might need to go and seek therapy to help you get over that thing. So life traumas and stresses, over-exercising or under-exercising, so under-moving, can actually be a stressor as well. And as we know, many women struggle with weight gain, so might be doing the wrong type of exercise for themselves, skipping meals. So if you're working long hours or you're shift working, all of that will cause stress to the female body. If you're been on a diet all your life and avoiding eating fats, and we need fats in our diet because it makes our sex hormones, and going about hair loss, you know, we need to be absorbing those fats as well so that we make those, you know, we're able to grow hair as well. deficiencies in nutrients, food intolerances, all these things can have an impact on our bodies and cause like silent stressors as well. And there's a lot of research around organic pollutants now, you know, and the link to cardiovascular disease. So where you live, the things that you're exposed to on a daily basis in terms of toxicity can also be a stressor. And then we've all got life stressors, and we've gone through 2 years of you know, COVID, and that we know that women bear the brunt of that as well. So when we talk about stress, we have to look at all of those things, and that is the domino effect. And so then we have to do all those things, those life stress management tools that we have in our tool bag to actually enable women to feel good and look good and have unshakable confidence. So if we just go to slide number 7. What's the approach? You know, I have a 5-pillar approach to supporting women in this phase of life, and optimizing your nutrition is really important. But what is right for you isn't right for everybody else. You know, there isn't a one size fits all. And quite rightly, you know, having this, you know, blanket nutritional plate that we talk about, making sure you're eating lots of fats, protein, you know, whole foods and everything. But actually, when you really start to monitor how you feel on a daily basis, really gives you clues. You become your own detective. How is that food that you're eating? How is it impacting your brain health, your energy, your fatigue, your anxiety? You know, how is it impacting you when you eat a meal? So taking a real in-depth detail of how you eat, when you eat, actually impacts you. Lifestyle, we've talked a lot about lifestyle, and I've mentioned before, you know, your exposure to natural daylight. It's such a simple thing that's free. It doesn't cost anything. Go out for a walk in your break, you know, maybe walk to work. Now the sun's out in the evening, maybe you walk home from work, maybe get off the bus slightly earlier. Just doing natural, exposing your eyes to natural daylight has a massive impact on our bodies. And if you're shift working, or working long hours, I know that's quite challenging for you. And I really believe that we need to test. There's so many things that else could be contributing to your symptoms in this phase of life. You know, B12, for example, folate. Is there any inflammation going on in your body? Are you potentially diabetic or on the crust of being diabetic? What's going on with your cholesterol? You know, speak to your GP and have a full test. You know, what's your iron levels like, for example, and ferritin. And then obviously something that I'm really passionate about is your gut health. What is happening with your gut health? Is that also a little stressor that's going on that you're unaware of? And so when we come together, we start to work on all these things, and they do work. The other things that I do focus on is mindset. I think we've had conversations around that, but really great tools like NLP, hypnotherapy as well, really helps women in this phase of life. And then, you know, supplements, and good, clean quality supplements that are evidence-based to support women as well in this phase as well. So that, I think, is an approach that I would take for each woman, and for her to really understand herself. So ultimately, it's about understanding yourself and becoming your own health advocate. So thank you, Jackie, for giving me that space to say that.
No, very welcome, and apologies that we continued with the questions that we were in a flow there. So quite a few aspects. So the Q&As are flowing in still. There's a couple of questions around organisational access to Pepi Health I've gone through. Pepi Health needs to be commissioned, people, so your organisation needs to work in terms of knowing its demographic. Know your demographic, your staff affected, and HROD colleagues will be keen to work. Pepi will be keen to work with your leads in this, I'm sure. I don't know whether there's anything you want to add, Kathy.
You're on mute.
Yeah, trying to unmute. Oh, switching teams.
There you go. You're right. You're live, Kathy. That's fine.
Am I? Sorry, it looks as if I'm still muted. You can hear me?
Yes.
Yeah, okay. Yes, so thank you, Jackie. Yes, I mean, of course, we want to talk to you about Pepi. Do get in contact with me, either me, Kathy with a K, Kathy@pepi.health, or you can just send it to hello@pepi.health, and we can give you all the information. We'd love to work with you.
Thank you, Kathy. One or two comments of a personal, specific nature, unfortunately, we can't all pick up. So I'm going to draw us to a close on there. Fantastic comments today, loads and loads of perspectives. Thank you for being so generous with your time, panel, and the expertise, bringing every different aspect of this transition together. Lots to think about. The recording will be available for RCN members and will be, the contact details are there. You can access that, and also let's not forget the piece by Deborah that has been published. The link is in the chat. So thank you all for today, and we will end the session there. Thank you all and stay well. Bye.